So today's session, we're going to be talking about hepatitis. So what is hepatitis? Itis indicates as inflammation of the liver, and hepatitis is, or itis is inflammation, and hepatitis is inflammation of the liver. So what are the causes of hepatitis? There are a number of different causes. They could be viral causes or non-viral causes. Viral includes as hepatitis A to E, and there are other viral conditions as well. And non-virals, just to list two, are toxins and autoimmune. So what causes inflammation of the liver when there is a viral infection? So when there is a viral infection of the hepatocytes, the cells of the liver, our immune cells, in specific our CD8 T cells or cytotoxic T cells, recognize this infected cell and induces killing. And this results in inflammation. So in fact, it's our own immune cells that are recognizing these infected cells that are actually causing the inflammation. So here in the diagram, we've got a infected hepatitis B hepatocyte, and our immune cell has recognized this, and through these two pathways, the fast cell and the perforin, it induces killing of the cell. And also there are cytokines released, which suppress the reproduction of this virus. Furthermore, it can also induce other cells to release chemokines, which are extra chemical messengers to recruit polymorphonuclear cells like neutrophils and lymphomononuclear cells, so like our macrophages and our NK killer cells. And these help amplify this process as well. So while all this inflammation is happening in our liver, we're going to have a few acute symptoms. So this is fatigue, malaise. The patient might complain of nausea or vomiting. They might complain of poor appetite. So as you can see, these are non-specific symptoms, joint pain. Then here comes our more specific symptoms. When we have jaundice, dark urine, and light-colored stool, this is due to the leakage of bilirubin into our bloodstream. So bilirubin that's usually processed through the hepatocyte and exits through our bile duct into our gut is now impaired because of our inflammation in the liver, and thus there's a leakage of this bilirubin into our bloodstream. So now that's why we're seeing our coloring of the skin as jaundice. Now, then, as the inflammation keeps progressing, we can have chronic symptoms, and chronic symptoms comes from more of the failure of the liver. So liver is important for a lot of functions. It has a lot of functions. And failure of this and failure of these functions can then result in clinical signs. So when we see coagulopathy, we can see bruising. When we see ascites, so our liver is now impaired, and now the fluid is now backing into places like our abdomen, and peripheral edema. So this is also signs of liver failure. Our liver is very important for producing albumin, and thus there's going to be less albumin. Helps retain fluid within our intravascular, inside our blood cells, and thus with lower albumin levels, we can see an increase of fluid in our interstitial spaces. Now, once a patient does have cirrhosis, some of them may progress to have hepatocellular carcinoma, and this is an important malignancy to screen for these patients. So here we can see jaundice, yellowing of the sclera as well, with the yellowing of the skin, bruising and ascites as well. Here we can see the distension of veins and bruising as well. So let's talk about hepatitis A to start off with. So these usually result in acute hepatitis and not really, we don't see them in chronic hepatitis at all. So they're transmitted through fecal oral route. So usually through the ingestion of contaminated food or water, and it's associated with poor hygiene. So in terms of the hepatitis A virus, these are positive sense single-stranded RNA. So positive sense means that this RNA can be directly translated to the ribosome once they infect the host cell. So once this virus gets into a host cell, that can use this RNA and directly go into the ribosome. If it's a negative sense, this then has to be transferred to a positive sense in order to be transferred into the ribosome to then make proteins and then to assemble new viruses. So there's a single-stranded RNA. It's non-enveloped, so it has a strong capsid outer structure. So it's packaged in a protein shell. So there is VPG, so a viral protein, and this is used as a primer for transcription once inside the host cell. Now, hepatitis B. This is responsible for acute and chronic form of hepatitis. Transmission is parental, and so that means it can be gone through bodily fluids, through sexual contact, IV drug use. Some of these risk factors associated with hepatitis B. It has a partial double-stranded DNA, which will then have to be converted to fully double-stranded DNA, and it has a viral DNA polymerase that can assist with that too. It has a nucleocapsid protein core, which is actually inside of a lipid envelope. So this is different from hepatitis A, which only had a capsid outer shell. So important surface antigens, so important antigens here that we should note of. There is a surface antigen on the outside. There are 3 different types: large, middle, and small. We also have a core antigen in the middle. So here's our core antigen. And this is very unlikely to be seen in the blood, and it usually stays inside. And therefore, we don't really order this as in terms of our blood tests. And we'll see more about this in the upcoming slides. And then there's an E antigen, which is a splice variant that also exists around here as well. Hepatitis C. So very similar to hepatitis B. It has an acute and chronic form. Transmission is very similar to hepatitis B. It's a positive sense, a single-stranded RNA. It's again very similar. It has a protein capsid inside a lipid membrane. And in terms of the important proteins to remember, it has E proteins on the outside, as you can see here. And these mediate attachment to host cells and allow the virus to enter. So what's the difference between this envelope and capsid layers? So when we have our lipid layer, this is derived from the host cell membrane, which makes sense, as the host cell membrane is also a lipid layer. The capsid, or the non-enveloped viruses, are more stable, which makes sense as it's a very strong structure and it can survive in the environment for longer. The lipid layers are more sensitive to the environment, such as heat, and thus has limited survival, and therefore relies on other routes of transmission, such as bodily fluids or blood products, sharing of needles, and those sorts of things. The lipid layer has an added advantage by adapting surface proteins, and this can allow to evade immune system and are more responsible for chronic hepatitis, like hepatitis B and hepatitis C. So investigations. So these are just some of them. Important ones to do with our full blood count, which can reveal elevated white blood cells. You can do a liver function test, and it will show that your ALT is usually higher than your AST. You can also see elevated bilirubin levels in this as well. And then it's important to get your hepatitis panel screen. So you're doing A, B, and C. So let's interpret them. A and C are quite nice and simple to remember. In hepatitis A, you order an anti-hepatitis A virus IgM, and this will be elevated in an acute setting. In terms of hepatitis C, you can get an anti-hepatitis C virus IgM in an acute phase and an IgG in a chronic phase. You can also get an RNA level, and that can indicate the infectivity of the patient. Now, hepatitis B is a bit more challenging to understand, but let's go through it. So we've got our surface antigen on the outside, and we've got the protein E on the inside. So here's our protein E. And this correlates with infectivity and viral replication. So when it's elevated, we know that the virus is actively reproducing because this gets ejected out of the viruses and is more present in the blood that we can detect. The core antigen sits inside the virus, and this is generally not detected in the blood. So there's no point testing for it. So we've got our anti-surface antigens. So our antibodies against our surface antigen. So this are antibodies against hepatitis B surface antigen. And then we could also test for the antibodies against the core. And this can be split up into IgM in our acute phase and total, which includes our IgG. We can also test for antibodies against our protein E, the infectivity one. And when this is elevated, we know it correlates with low infectivity because it's kind of going against the E protein. So it neutralizes its effect. We can also order a DNA level, and this can test for viral load. And we can combine this with our um, E antigen to indicate how active this virus is. So in terms of this graph, let's interpret. You can see that your surface antigen and your E antigen peaks, and our antibodies take some time to build up. Then our next one that builds up is usually our IgM of our core antigen, while our total, which includes our IgG, takes some time for it to reveal. That's similar to our um, anti-surface antigen and our anti-E antigen. So these takes a little bit extra time for it to build up. So in terms of interpreting the results, if they're all negative, they don't have an infection, and the patient can be susceptible to a new infection in the future. Now, if the anti-core antigen, so antibodies against the core antigen is positive and antibodies against the surface antigen is positive, but they have no surface antigen present in their body right now, we know that there is no active infection. So this is our sign for active infection. So if I'm worried they're having an infection right now, I'm going to be looking at this value. And so this indicates that there is a past infection and it has been resolved. So the patient is now immune. If just the antibodies against the surface antigen is positive and everything else is negative, this is because they have had a hepatitis B vaccine. So hepatitis B vaccine is based off the surface antigen. They only use the surface antigen to mount an immune response for the vaccination. Now, if the surface antigen is positive, like I said before, we know that there's an active infection in the patient. So now I look onto my other tests. Okay, my antibodies against the core antigen is positive, and in particular, the IgM is positive. So I know this is an acute infection happening at the moment. If there was a similar sort of thing, but the IgM is negative, then I know that there's a chronic infection happening at the moment. Now there is some, when just the antibodies against the core antigen is positive, there is different sorts of possibilities, and this should be further investigated. So if just the core antigen is positive, then we should be thinking whether this is a resolved infection. So it's just been resolved and it's taking some time. If there is a false positive, if there's a low-level chronic infection, or if there is a resolving acute infection. So these are important possibilities to consider. So clinical course of hepatitis A virus. Usually this is spontaneous resolution, and we should only be managing the symptoms. In terms of preventing, immunization, especially for travelers going to these endemic areas where they're more prevalent, sexually active, especially men who have sex with men, and chronic liver disease patients, especially with those with hepatitis B and hepatitis C, and just chronic liver disease as well, as this can further have an impact on the disease, which is already impaired. The liver is already impaired. We want to prevent any further impairment. In terms of hepatitis B, most of them resolve spontaneously. So we've got an acute infection of hepatitis B. Most of them have a subclinical infection and recover. Those that have an acute hepatitis, very rarely it results in something called a fulminant hepatitis, but most of them recover. A small proportion to go into chronic hepatitis. And most of these, even if they go into chronic hepatitis, they do recover, have a spontaneous recovery as well. But again, a subset of these patients then progress into cirrhosis and then can further develop hepatocellular carcinoma. Then we've got hepatitis C virus. Here, the chronic hepatitis is actually, unfortunately, more common. So we can see that only a small subset of them actually spontaneously clear, and a large proportion of these patients go on to have chronic hepatitis. Then a subset of these patients will then have cirrhosis, end-stage liver failure, and then this is further complicated by decompensation due to cirrhosis, hepatocellular carcinoma, or death. So cirrhosis is here. It shows that there is a 1% per annum decompensation. And all patients should be then considered for antiviral therapy. So for hepatitis B virus, we need to talk about our management options. So there's interferon therapy available for chronic hepatitis B viruses, because if there's an acute hepatitis, we know that there is a strong chance of recovery. So it's usually only indicated for chronic cases to prevent that progression into cirrhosis. Furthermore, it's also indicated in all children infected with this virus, because in adults, while a lot of them do recover and have spontaneous recovery, a significant proportion of children actually end up having chronic hepatitis. Because of the large proportion of hepatitis C progressing into chronic hepatitis, all of them should be considered for antiviral therapy. The goal is having a negative RNA, so viral load at 24 weeks post-therapy. So that's the conclusion of hepatitis talk. I'm curious to hear if any other topics that you'd like me to cover. Comment down below if, any topics I should cover next, and I'll look forward to seeing you guys next session. Thank you.